Thank you very much, Anna, and thank you for being very kind with your introduction. I'm James, some of you know me. I'm a paediatric anaesthetist and a HEMS doctor, which the picture kind of gave away, didn't it, really, a little bit, with the Air Ambulance Service in the Midlands. And we are going to be talking, and obviously I run this thing called KidConfident.org, which is a website for pediatric education, I guess, for paramedics, so or anyone pre-hospital. So if you haven't checked it out already, check it out as well. But tonight we're going to talk about mastering pediatric assessments, and I've got some objectives. Basically, we're going to talk about something that I call the KidConfident approach, but it's a standard approach to assessment in pre-hospital settings for children, and help us use some structured assessment tools to identify pediatric illness and injury, recognise red flags, including red flags for safeguarding concerns, which is increasingly important thing, and use history taking to help guide our decision making. Now, obviously, because this is trauma care, you're going to be interested in injury, but I'm going to show you a structured approach to assessment of any child, whether it's illness or injury. So you will hear me talking about illness as well as injury, but understanding that this is trauma care, so we will be looking at this. Lots of the serious injuries also share clinical signs with illness presentations. So the whole basis of the KidConfident approach is to perform a physiological assessment in a structured and repeatable way to allow you to feel comfortable, whatever the presentation is, and then put it into context, as you'll see in a minute. And we talked about safeguarding, and actually I'm going to start this now and lead with it. This is something that's usually left to the end, but I'm going to leave it at the beginning, because our safeguarding assessment actually starts the moment we pull up outside a job, even if we haven't really realised it, because we start taking in information about the environment, the family, the parents' ability to cope with the child, and then the child's developmental needs and how they're being met. So it's not really a snapshot assessment that you do intentionally, but it's a picture that you build up over the time that you're with the patient, and that's from when you pull up to when you're handing over in hospital. This is a triangle that social services use and the social workers use to look at when they're making an assessment of a child's safeguarding and welfare needs, and it helps us make decisions or judgments which may have a huge impact on the rest of the child's life, both medically and psychologically, and it may influence their trajectory in life. So it is quite important, and that's obviously why the social workers and the social care system put so much emphasis on this particular triangle and system. It's really important for us to acknowledge this as an assessment and not just a bunch of stuff that we noticed, and put it together and hand over our concerns. Because in the context of traumatic injuries, we need to consider non-accidental injuries. And this is another huge topic on its own, so we won't be covering it in depth here, except to say that it is taking a thorough history and performing a structured examination and being aware of what's around you will provide all the clues that we need to raise concerns once the child is at hospital. But handing over the concerns at hospital or anywhere else isn't enough on its own. We all need to escalate those concerns, and this is best done by following our local protocols and procedures, as I'm sure you've had drummed into you many times. More often than not, the factors around the triangle lead to NAI, or non-accidental injury, and spotting them as a problem can help reduce future injuries and then improve the psychological well-being and improve social outcomes for the children affected. So it's really important. As soon as you arrive at the paediatric patient, this assessment starts, and it doesn't finish until you hand over your patient, when you also need to hand over your concerns and initiate any referrals that need to be made yourself. I'll put a link at the end of this, or I'll put it in the description and chat, so that there's a page I've made on the KidConfident website for today's webinar, for tonight's webinar, and it's got a little bit more information about all this sort of stuff. So you don't have to like memorize that whole triangle. It's just good to be aware of the sorts of things that people look for when they're doing these sort of safeguarding assessments. And that is all I'm going to say about that, because otherwise you'll all click off. So the KidConfident approach to assessment is a structured, systematic and confidence building framework. It's a little bit made up by me, but most of the components are things that you'll be familiar with. So it's starting off with the paediatric assessment triangle, moving on to an ABCDE examination and approach to your patient. And then in children, this is especially important, looking at joints, ears, nose and throat, because that's where you find loads of hidden mysteries that you might not or otherwise spot, and that can help you a lot with your decision making and your decisions about what's going on with that child. And obviously always get a good history, which we will talk about as well, and that can help you focus your examination if needed. This approach gives you a global impression. Start off, well, are they sick or not sick, and why? And then you're ruling out the life-threatening problems, and then looking at the common problems that needing attention, and identify your red flags quickly. So the paediatric assessment triangle, which I'm sure you've all heard about and think is really underused, and it's a really valuable tool. It helps pre-hospital providers make a quick, slick assessment of children, and it's telling you if the child is sick or not sick, and it's a beautiful thing because it allows you to make an assessment without using any equipment and without even touching the child. It's amazing. It's not a diagnostic tool, and that's important to understand, but it allows you to make a quick assessment of how unwell the child is and where to focus your attention. This in turn helps guide your decision making about how urgently the child needs to have any treatment or interventions implemented. Obviously, triangles are made up of 3 sides or components, and in this triangle, the 3 sides are appearance, breathing, and circulation. All you have to do is assess these 3 components in turn and decide if the child is sick or not sick in that area. And then by putting these 3 parts together, at the end, you get an overall impression of the child's sickness status and how it's affecting them. So let's have a little look a bit more at that. The first component is A for appearance, what the child looks like, obviously. And the mnemonic I like to use for this component is tickles, because everyone likes tickles. So T is for tone. Is the child moving around normally, laying down listlessly in bed, unable to lift up their arms? If you go near them or a parent picks them up, do they move or resist movement, or are they just floppy and going with it like a sack of potatoes? And I is for interactiveness. This needs to be based on the developmental stage of the child. So babies can smile from around 6 weeks old and should be looking around. As they get older, they start to fix and follow. So for this part of the assessment, you want to see if the child is looking around. Do they look at you when you walk in a room? Are they looking at their parent and interacting with them? Do they follow you as you walk around, looking at you suspiciously? And how alert is the child? Which is a really good thing. How alert is the child, and are they watching you appropriately? That's what you'd be looking at, because you're a stranger and they should recognize this. And some may not want to engage with you, and that's normal because you're a strange weirdo in green or orange in my case. But they should react differently to a parent or a caregiver, which brings us to the next part, which is consolability. Most children should be able to be consoled by their parent or caregiver. If you notice that a child is unable to be consoled despite the parent or caregiver's best efforts, then something ain't right. L in tickles is for look and gaze. We kind of looked at this a little bit with the interactiveness, but it's specifically observing how the child is absorbing what's going on around them. And did they notice your arrival? And did they move to look at you, or are they just staring into space blankly? And then speech and cry. This depends on the child's developmental stage, obviously. And all kids cry, and it's really annoying. Having 2 children, my own, I know it's even more annoying when it's your own child. And it's hugely appropriate for a child to cry around strangers. So don't be put off if you turn up and they start bawling. If they're not, then that could be a red flag that they're a bit poorly. So in this part of the assessment, we're asking, is the cry normal? And this is when putting the findings into context comes in. I like to ask the parent or the caregiver, do they sound like they're speaking or crying normally to you, or is there something unusual about this that you've noticed? So like a high-pitched or a hoarse cry or voice might be a sign that something is going on, and this might be an upper respiratory tract infection, or it could be a sign of laryngeal injury in the context of trauma. Is their cry strong, or is it weak and hoarse? That's an easy question you can ask yourself. So we've had a first look at the child, and we've decided through this assessment, am I worried about the appearance of this child? Yes or no, nothing else. Looking at those little details, obviously. So then the next part is breathing, and that's specifically the work of breathing and how much effort the child is needing to make to maintain oxygenation. Again, this needs to be put into context. So an increased work of breathing might be a sign of a chest infection, but it may also be a sign of thoracic injury and trauma. I can't think of a mnemonic for this, but if you can, then please share it in the chat or comment section. There's quite a lot of signs that you can pick up here, so they aren't all in the picture, but we will talk about many of them now. First thing to note is the position of the child, because sometimes when there is an airway obstruction or other problem with the airflow, they try to change their position to optimize this. Changing position can alter their airway diameter and improve the airflow through the airway. This may be by extending their neck into a sniffing position to open the airway, more like we would do to open their airway, or they might adopt a tripod position with their hands on a bed or on their knees, which engages their accessory muscles with less effort. These are red flags for respiratory distress, so recognizing this is properly important. Because position is all about airflow optimization, I'm going to include nasal flaring here, and in some children, especially younger kids and who are obligate nasal breathers under the age of 2, they flare their nostrils to increase airway diameter and improve flow. This can be subtle, so you have to look at it specifically, and when you do, you'll notice that their nostrils open up more every time they breathe in. And this is increasing their overall work of breathing and counts as a concern in this component of paediatric assessment triangle. Tracheal tug, easier to spot. You just look straight at them, look at the trachea and see if it's going in and out with each breath. This is increasing their work of breathing, and that should be alert to you that there's a B problem. It's also so often, but not always, associated with head bobbing, which is also hard to spot because it can look like they're just moving around normally. But like nasal flaring, if you look for it specifically, you'll notice that the head movements are aligned with their inspiration and expiration and alert you to increased work of breathing and therefore a B issue. And then you've got abdominal breathing, it's just a sign of increased work of breathing. It looks like their belly's doing all the work rather than the chest. And this can be a sign of injury or that the child is starting to tire as their respiratory muscles are maxed out. And then noises, really important. Some noises like stridor or grunting are red flags for respiratory distress, but other noises like wheezing or snoring can help give you some diagnostic clues later on as to what's going on. Grunting is especially concerning because it means the child is trying to breathe against the closed glottis, and that grunting noise you hear with every breath is a big red flag. And then finally, you've got your subcostal and intercostal recessions, which are a really important sign of respiratory distress. Looking at the chest, you'll notice the chest is being drawn in between or underneath the ribs when the child is breathing in and out. And this is a sign of significant effort being made to maintain ventilation, and it should never be ignored. In younger babies, it might not always be obvious because they're a bit chunky, but they may provide an additional clue when we call periodic breathing, and this is when they like breathe normally and then it seems like they go faster and then slower because they've got immature compensatory mechanisms, and this just adjusts to every little physiological trigger, and this can be normal for some children, though as their physiology matures, it should calm down a little bit. So it's worth asking the parent or caregiver if this is a normal breathing pattern for that child. And then the last part is the circulation. This is possibly the hardest area to assess, actually, because you can miss subtle signs of a circulatory problem if you don't get a proper look at the child, and that can be difficult to do in some circumstances. Ideally, you need to get the child properly undressed at this point to make a good circulation assessment, but the signs can be seen even if this isn't possible, but you do have to look for them specifically. And obviously in our pre-hospital environment, getting them completely undressed might not be appropriate or sensible. So it's good to look for specific signs on the peripheries as well. Pallor can be really challenging. It's one of the first things you look at your C assessment, because different skin tones can upset your radar here. And the question to think of is, does this child look pale for them? Not does the child look pale to you? The best colour chart for this is the parent or the caregiver's opinion. So don't be afraid to ask if they look a normal colour or not. And if not, then why not? Sometimes you can look at the mucous membranes. That can be helpful because they're more consistent colour, whatever skin tone, and pale mucous membranes can often be easier to spot. Mottling is when there's patchy discoloration of the skin caused by variable vasoconstriction. It's most common in the extremities, and it's a red flag for circulation because it's a sign of reduced tissue perfusion, and it can also affect the whole body, which is a double red flag. Cyanosis, third bit we're looking at, and although it's a sign of hypoxia there, and therefore respiratory problems, it is from observing the circulation to the skin that we see it. So the bluish discoloration is most common around the mouth, and also around the fingertips and toes, where you may notice the nail beds look a little bit blue. And this is a massive red flag for hypoxia and reduced oxygen delivery to tissues. In trauma, all of these signs are evidence of bleeding until proven otherwise. And similarly, in illness, there are perfusion problems which need to be addressed. So you've completed your assessment from each side of the triangle, and decided if there are any appearance, breathing or circulation signs that are potentially concerning you. And remember, each section is just a yes or a no, am I worried or not. There's no academic thinking or diagnostic gestalt here. It's simply a yes or no answer for each component. You can worry about the rest of the clever stuff later, or pass that on to someone else to worry about. But all of these signs need to be taken seriously at the stage. So you put together these components, and we can work out how worried we are about the child and have an idea what might be wrong with them. You can see from the picture on the screen here that a child that has normal appearance but some signs of breathing problem has a breathing problem. But when you combine that with abnormal appearance, then it becomes more severe, and respiratory failure is present or impending. And a child with findings in each of the three components is in decompensated shock or cardiorespiratory failure, and that's really bad in their peri-arrest. So that should just be a little warning to you, even if all of their numbers are good and you can't find anything else, the child is sick. There's an interactive version of this on the KidConfident website in the resources section, and it links to an awesome tutorial from Don't Forget the Bubbles as well, where you can have a deeper dive into the theory behind it if you want. But hopefully you can see that the appearance of the child has a significant impact on how sick or stable you think the child will be. And you need to remember this as you move through the rest of your assessment, because children can have annoyingly normal observations right up to the point where they don't. And this is where all that scaremongering comes from, that kids just decompensate and fall off the cliff without warning. Hopefully you can see now that this isn't true, because there are sometimes some subtle, non-specific signs that can alert you to the physiological condition of the child behind their compensatory mask. And this is the amazing power of the paediatric assessment triangle, which is often overlooked as an assessment tool. We all learn it and then we all think that, and actually having started to use it purposefully, I've actually noticed the value of it. So go for it and start using it, and hopefully you'll notice the value of it too. I use the same principles in adults too now. It's that good, because these physiological signs are not necessarily age specific and are indicators of physiological derangement, not pediatric specific problems. So I found that they're really, really useful in all age groups. So that's the first part of the KidConfident approach, is the paediatric assessment triangle. And then step two is the A to E assessment. And this is something that you all know how to do absolutely backwards. So this gives you a familiar structure to follow and be confident with doing. It doesn't have to be reserved for the sickest patients. It can be a really useful approach to all patients, and it can be used to help you remember to do all your observations and check everything. When I work in A&E before, this is what I would use for literally every patient, and every patient I see on HEMS, I do the same sort of thing. I use an ABC approach for every single patient. Because it's familiar to you, it's well practiced, and you're just going to bash it out without any problems. You can do it if you're on your own in a longitudinal A, B, C, D, E approach way, or if you've got a mate with you or a team, then you can do it, things together, can't you? Just save some time, make it more efficient. And because we're in trauma, we've got the C, A, B, C, D, E. Little change with a big C at the beginning, but hopefully you can see that the A to E assessment generally doesn't change. The primary survey is a primary survey for life-threatening injuries. The same things kill children as adults in trauma, and these are most commonly the airway obstruction, massive bleeding, and head injuries, which is the highest cause of death in trauma in kids. Part of the A to E assessment obviously is your 12C examination, looking at the neck and looking for your tracheal deviation, wounds, emphysema, laryngeal tenderness, distension, esophageal and jugotic hematoma. And these are, again, subtle signs that might be present in an otherwise well child, and that can alert you to the fact that actually there might be something going on and they're compensating. So this is a good structure for your your airway, your A/B exam. And then you've got to work out we can work for our primary survey examination to find my favourite football team after Crystal Palace, obviously, and this is the life-threatening things that you need to find in trauma that kill people really quickly. And the idea is to find and treat these issues during the primary survey, the same as in adults, and more on that in the next webinar, which is about management. So ABCDE approach, it's a familiar system to use for all your patients. A, B, and C is your chest and your airway. Put your obs on the monitor and do your capillary refill time, more on that in a second. And then in D, I put GCS, pain, movement, and a fast assessment, and put glucose. Don't ever forget glucose. Don't ever forget glucose. And I said we're going to talk a bit more about capillary refill time, which I'm sure you all know about. Is blanching pressure for 5 seconds and then timing how long it takes for them to go back to a normal colour. And we're all told that capillary refill time under 3 seconds is a red flag for circulatory compromise. But do we do it peripherally or do we do it centrally? And what is the evidence? And when you look at this, actually, we're all told, I think, to do it centrally, where actually peripheral might give you a quicker capillary refill in the upper limbs, but slower capillary refill in the lower limbs, and your central capillary refill should be about the same as your lower limbs, which kind of makes sense if you think where the blood vessels come off. The evidence for it does exist, but it's based on some really, really small trials. And so this can often mean that clever people argue about capillary refill time. However, my rationale for doing the capillary refill time in every paediatric patient is that the physiology makes sense, because if you've got volume depletion for any reason, it causes vasoconstriction. That's a normal physiological response. And vasoconstriction is designed to maintain blood pressure, and therefore your reflexes will improve, mean that the heart rate is improved. But because your blood vessels are constricted, it will reduce your capillary refill time. And when we've looked at case reviews of sudden deteriorations of paediatric patients, it's always been noted that a prolonged capillary refill time has always been present. And so I think this is really useful. And I think this is something that, again, gives you a massive heads up to the fact that this child is compensating, and that scaremongering about them falling off a cliff might be something, but you'll be prepared for it because you've done your paediatric assessment triangle, you've looked at their appearance, you're working through your structured A to E, and you've done a capillary refill time, which you've noticed is a little bit prolonged or a lot prolonged, and you're ready for it. So you will act on it and not get surprised if they get poorly, or even better, prevent them from falling off that cliff by acting on these findings. So back to our ABCDE assessment. And yeah, I forgot, why do people always bang on about the BM in kids? It's like a thing, isn't it? Actually, why do they not bang on about it enough? Because hypoglycemia can be relatively common in critically ill children, even in the non-diabetics. And the younger the child, the more susceptible they are to hypoglycemia as a result of illness or injury. And this is especially important in trauma, where head injuries are the biggest cause of hospital admissions, and doing a BM is regularly overlooked. And the reason it's really important is because the brain almost exclusively uses glucose and oxygen to metabolize and create energy. So when the body is in a stress state, glucose and oxygen utilization is absolutely through the roof, and this can be seen through brain activity, which we can measure. really easily, in fact, and it's one of the first things we spoke about in the paediatric assessment triangle, because central nervous activity is responsible for tone, interactivity, irritability or lack of consolability, and speech. So it's the appearance component of your paediatric assessment triangle. But we're moving on we're on the next stage of our assessment now. So we can focus on how this is affecting the brain and quantify it better. And we use our GCS score to do that. And there's even approved adaptations to the adult GCS for use in children and non-verbal patients, including autistic children or adults, and those with learning difficulties, and also in babies, and as you can see on the screen. So in cases involving potential brain injury, this is a really useful prognostic tool which helps guide management. And in medical cases, this also gives us a clue to the physiological effect of the illness on the patient. And it's a tool that we're all used to using in adults, and we use it probably every single day. And it's not just brain activity from hypoglycemia that affects it either. This is a core assessment for any trauma or head injured patient. And hashtag available to download at KidConfident.com. No, .org, not .com. Yeah, it's too expensive. So moving on for the D assessment, D part of it is looking at pain. This is a whole topic in itself, and I do need to say though that assessment for pain is vital. Children experience pain, and it has a significant impact on their well-being if it's not treated. They might not always tell you they're in pain though, because they're in too much pain. Overtreating can have serious adverse effects too. So choosing the right tool for assessing pain is important, and so is reassessing after making an intervention. This poster on the screen at the moment, along with more pain management posters and all the pain assessment tools, can be found for free on KidConfident.org website for you to all download and use. And there's also a free ebook as well, which has been done with the Pediatric Blast Injury Group, and it covers all aspects of emergency pain management for injured children, and has loads of really useful information and tools to help you assess and manage pain in children like a pro. Handing this information over to a trauma team, for example, can have a huge impact on how they manage the whole patient, because a well-analgesed child, which you deliver them, may not be as well as they appear, but that isn't an excuse to undertreat and promote larger physiological stress response down the road, which will obviously have negative impact on their outcome and cause psychological issues for them, including their relationship with healthcare providers, and significant impact on their long-term quality of life generally. So treat the pain, do a good job of doing it, and make sure that you tell the trauma team how well you've improved the situation, so that they take the patient seriously and they get the best outcome. So getting towards the end of this now, you'll probably be glad to hear, in E, exposure and do everything else, abdomen, skin, temperature, limbs, and remember that skin is vitally important to detect signs of injury or illness such as bruising or rashes, but it also helps with your assessment of safeguarding needs. With immature thermoregulation combined with relatively greater body surface area, the younger the child is, so they get a bigger body surface area the younger they are, and then it gets to more normal. So identifying hypothermia or hyperthermia helps guide your management and provides clues to the pathology as well. In a trauma patient who is cold, it may be a sign of bleeding. A medical patient who is confused or off balance with a temperature may have a severe infection or sepsis. So you can see that an ABCDE approach provides us with a great structure for all our patients, however they present. So this never happens, does it? A proper examination always helps prevent surprises. So examine the chest, you might find something relevant that you didn't expect, like inhaled foreign bodies, respiratory illness, absent air entry. And while you're there, you can check for the heart sounds, or the banging drums, I like to call them. But it never seems as easy as it does for this guy in the picture. However, there may be some tricks to help you make it happen a bit more like this. Parental involvement is one of these, and remember we said at the beginning it's normal for younger children to be skeptical of you because you're a stranger. The parent or the caregiver, involving them, it's not only comforting for the child, but it gives them a job to do as a parent and or caregiver, and gets them involved in the care. So it stops them bothering you with stuff whilst you're trying to figure out what's going on. And it's a form of distraction for the parent and helps focus their attention on helping their child. And also, by involving them, it's easier to explain what's going on because you just develop verbal diarrhea like I do and talk as you go along, which is great for the child, and it's good for the parent or a caregiver. But most importantly, it's great for you because nobody else can get a word in edgeways to argue. And it's great CRM because everyone knows what's going on in your team. And it's a brilliant way of calming everyone down with your reassuring tones of calm and tranquility. So practice them. Making it a game is great as well. It's great for building rapport, gaining trust from the child, and getting the necessary things done. It doesn't have to be boring and formal, so let toddlers and babies play with your stethoscope before you put it on them. Do high fives with any opportunity to congratulate the child and create that rapport. And if you don't know what to talk about, do like you do with old people and ask about something that looks interesting, like their clothes or their toys, or ask them to tell you about their favourite TV program or computer game or anything. So this leads on nicely to the final part of our KidConfident approach to assessment, and I have to hurry up because I'm running out of time. And this is the JENT exam. Now, this is the bit that I've completely made up myself, but it's something that I learned how to do when I was doing paediatric placements as a medical student and as a doctor. It's not in any of the textbooks as the JENT exam, but the principles are, so we'll have a look at it and just allow that. We need to look at all the joints and ENT to find otherwise hard to spot clues of illness. So in trauma, we're looking for displaced joints or evidence of fractures such as bruising and swelling, and this impacts how we'll package and care for the patient. So it is really important. In illness, then swollen hot joints may be more pertinent findings to explain seemingly occult affections. So you might have a joint infection which hadn't picked up, and that's more common in kids than it is in adults. Making this a game makes it more fun and also helps find injuries that might otherwise be missed. If a child can beat you in a jumping competition, then they probably don't have any immediate serious injuries in their abdomen. However, if they start jumping determinedly and then freeze and complain of pain in their belly, you may have just unmasked a hidden injury that would otherwise remain undetected until it developed and shocked everyone later on. And this applies to all intra-abdominal pathology. So I've found it's awesome at finding appendicitis in children with like randomly vague tummy ache as well. But it can be good for finding bleeding in kids from handlebar injuries who are otherwise looking well. And when you're examining the joints and the limbs, the process of look, feel, move is the standard approach, which I'm sure you've all learned and practiced hundreds of times. So making it more fun should be a breeze and a little bit more entertaining for you as well. And then after we've looked at the joints, we have to look for bogies and brains. It's your ENT exam. It might not always feel like a necessary thing to do in trauma, but foreign bodies can get overlooked, and that can be things from shrapnel, bits of gravel, and or whatever, and they can develop into big problems if they've not been recognised, and you might not do anything about it, but it might be something you hand over. If you work in a hospital or GP practice, this is a vital part of your assessment for all paediatric patients, and if you've got the equipment like oroscopes and things to have a look inside the ears, then that is something you should be doing because you can then pick up loads and loads of signs as to something illnesses or bulging tympanic membranes and all sorts of things like that. But sell it as looking for bogies and brains because it's more fun. Use Aide memoirs. I bang on about this. When you're doing all these things, that you're doing a lot of things and all the numbers are different, and that's what scares people a little bit. And it scares me a little bit, and my brain is really little, so I can't actually remember all the normal values for every different age group of child, even though I anaesthetize like babies all the way up to 16-year-olds. So I like to use Aide memoirs. My favourite one is the kid cards, and if you come to the trauma care conference, we might have some there to give away or for sale at cheap. But you've all probably got access to JR Calc apps on your phone, and that's got a brilliant age per page thing. And I would definitely advocate using that for looking up all your normal values and your drug doses for that matter. And then if you're really stuck, there is this freebie on the KidConfident website as well, in the resources section, which you can download and use to help you remember or look up each time your normal values. So last bit, we said that we were going to talk a little bit about history, and I will only talk a little bit about history because you're all well good at taking them. You do it every day for every single patient. This is the mnemonic, the structure I like to use for paediatric histories anyway, and that is history, imaginatively. And this helps you with your decision making, doesn't it? So you're putting together all your assessment examination findings with details from the history, which you probably don't do first when you get there, even though we're taught history then examination. It's probably all done together, but these are the points that you want to cover. You want to find out what happened, and are there any inconsistencies or doubts surrounding the history of events, and could this be a clue for non-accidental injury or other safeguarding concerns? Immunisations, they help your decision making about pathology, but also inform decision in hospital, and may also elicit some safeguarding concerns. And obviously with injuries, tetanus is an important immunisation to be aware of. Have the parents or caregivers noticed any symptoms or signs that come and go but could influence what you think is happening and how you're going to manage the patient? We've all heard that story that now you've turned up, they're absolutely fine, but they were like dog sick earlier. And then specifically asking about temperatures and details about the mode of injury can be really helpful as well for predicting what might be wrong with them. Premature children often have less ability to compensate until they're a little bit older and they've caught up with how old they should be. And knowing that they needed respiratory support in NICU or something after being born will lower your threshold for acting on respiratory findings in your examination. So that's a good thing to ask about their obstetric and perinatal history. Usually it was all fine and normal, and it was horrifying for the parents and all that sort of stuff. But occasionally you can find out these things, and it should just lower your threshold for acting on respiratory findings. Parental concern is probably one of the most important things to ask about, and I'm doing nearly a whole webinar about this coming up soon, but not here, sorry. If your assessment doesn't show any cause for immediate concern, and the child should probably then still get checked over by a paediatrician if you've got parental concerns and they're valid. Even if it's just to treat the parents and educate them with the benefit of access to investigations and more time to observe them, this can be a really valuable thing to do. And then the most important bit of the history is your clinical impression, and that's formed after bringing together all the history and examination findings. And it doesn't have to be a groundbreaking house-style diagnosis. Spotting that a child is critically injured or unwell and assessing if they need immediate interventions or if they just need treating in a decent time frame is what matters. And what those interventions are and how quickly you need to provide them will be guided by all your assessment findings, and will probably be quite easy to decide if you follow a simple, familiar and structured approach to your assessment like we've just talked about, hopefully. And this is true for trauma and non-trauma patients, probably of any age, but especially in children. And I think that bottom line there, this child is critically injured or sick with signs of decompensation, is a brilliant thing to hand over to a team, even if you haven't got a diagnosis, because they should really listen to. So there we go. We've had a really quick run through the KidConfident approach to assessing children. So we started off with our safeguarding assessment, which starts when we start and continues throughout the entire patient contact. And we're looking at the developmental needs of the child, parents' ability to cope, and looking at then the family dynamics and the environmental factors, which are all things that we will notice and probably comment on to each other afterwards. But thinking of them in these separate areas and putting them together as an assessment over the whole period of time might be really valuable to the child's care and long-term well-being. And then we get into the meat of it. We're doing the paediatric assessment triangle, figuring out are they sick or are they not sick and why, and looking at those three areas of appearance, breathing and circulation. We're not trying to diagnose anything. We're just saying, is this a problem or is it not? Then we're doing our ABCD assessment, which we do all the time, loads of times, and we're really good at. So we'll do that, and we'll pick up anything that needs sorting straight away, and we'll also we'll not miss anything, and have lots of information to help us make a decision. Don't forget to check your joints in the ENT examination to find any hidden mysteries, and then combine your assessment findings with the history to guide your actions. And that's it. That's it. I'm done. I am just going to do a little plug for KidConfident though. If you haven't been on the website, go to the website, kidconfident.org, sign up to our newsletter, and you'll get to find out about anything that we are doing, and get a copy of newest posters and resources and all that stuff straight into your inbox. Join our group on Facebook. It's Pediatrics for Paramedics group. We've got quite a few members on there already now, and we have like case discussions, live Q&A sessions, and it's a place where you can, if you're a member, obviously you can contact us through the chat privately and ask any questions or concerns that you have, or for more information about something. And we've just started our own YouTube channel because we love the trauma care one so much, and it's at KidConfident23, and if things like this webinar will be up there. Our previous trauma care webinars are up there, and I would really appreciate it if you checked it out and like, comment, subscribe, and share, because that actually does help KidConfident, and this is one of the ways that we're trying to raise some income so that we can pay for all the resources and the stuff that we do, because it's starting to cost a little bit of money, and we don't want to charge anyone for it, and we won't charge anyone for it. So just subscribe to the YouTube channel, listen to me driveling on, and we have got some more interesting content and videos coming up, so it's not just me waffling on the whole time. And that is it. So I think Anna is going to field questions and not ask me anything too difficult.
Oh, you copycat. You're absolute copycat. I'm glad you've got it going. It's about time. Just check that right. Yep. Okay, so before we move on to the Q&As, once again, James, thank you very much for another extremely informative webinar, as per usual, full of little tidbits and goodies for everybody. So before we move on to the Q&A, I just want to draw everyone's attention to our next webinar. James is returning in a couple of weeks. Do not worry, he's not going anywhere. We've got 3 webinars coming up soon, actually. But first, we've got John Hazeldine, who's going to be talking to us about a really exciting development that's happening at the moment in it's called the Golden Hour Study, which is all about sort of how the role of blood and saliva in this. And if you've not heard of it, it's basically a concept that he's very heavily involved in lab work, of taking blood from a trauma victim within an hour of the accident happening, getting it back to the labs, getting it assessed. And these markers that you find in the blood give a greater insight than we've ever had before into the extent of the injuries that could be going on. So do scan the QR code that's on your screen now to learn more about this really exciting concept, because it's going to affect healthcare as we know it. So it's going to be a great webinar for everyone. And that's on February the 20th, so 2 weeks' time. The Q&As. So I'm going to get the Q&A box open. I know Dawn has been doing as you asked, James, and answering little questions that have been coming up through the webinar as it's been going on. But if you have any questions, now is that you'd like James to answer, now is the time for you to ask them, and we shall answer. And if you are not a trauma care member, this is also your chance to scan the QR code that's on your screen now and purchase your CPD certificate for £1.99. However, loads of you have signed up to become a member tonight. If you have done that, put your phones down. You don't need to scan this QR code. You will get a free CPD certificate tomorrow. If you do want to sign up between now and tomorrow, you have plenty of time. I'll be sending them out about 10 o'clock in the morning as per usual. So you've got between now and then to sign up and you'll get a free certificate. If you don't fancy it, no hard feelings. Scan the QR code that's on your screen and purchase your CPD certificate for your portfolios. So a question that came up, it was also in the chat, but it's come up as an anonymous attendee's question as well. So I don't know if it's the same person. If it is, I do apologize, but I think it's good to read it out loud. So at one point, James, you were talking about mottling and sort of the discoloration of skin and pallor, and someone has asked, it's always difficult for them to ascertain pallor mottling in a person of color. So are there any alternative assessment points that you could be covering in that instance?
Yeah, so I think it is really difficult, and because it's can be hidden in darker skin, um, even if it's like a little bit darker like mine. And so I like to look at mucous membranes. Like you often see like people pulling down the eyelids and having a look at the conjunctiva. Looking at the gums as well is a good thing. If you've got pale gums, then you're really quite dry. And looking at the nail beds as well. So looking at the nail beds, if they're quite pale, that can be a sign that they've got some circulation problems. If you look carefully, even in the darkest skin, you can see some sort of changes that are there. So if it doesn't look normal and you're not sure, there's nothing wrong with asking somebody who knows the child better, do they look normal? And if there's a parent there or a sibling or something, they'll soon tell you if they look pale or if they're a bit discoloured and stuff. So that can be a really useful thing to do as well. But mucous membranes and fingertips is a good alternative.
Brilliant. And that was it. It was a slight expansion on the answer Dawn gave as well. I think trying to type and get through everything so quickly, you give the most. So wonderful to have the expansion there. An anonymous attendee again has asked, what is one piece of advice? What is one piece of advice you would give to a student paramedic with little to no experience with younger children and babies?
Say that again. Say that again.
That was my fault there for tripping over my own tongue. So what is one piece of advice you would give to a student paramedic with little to no experience with younger children and babies?
So I think that means like because they're not used to being around children and how to interact with them and stuff. I think the biggest piece of advice is to be yourself and try and have fun, which sounds weird when you're on a job seeing a sick kid. But if you're relaxed and playful, they're like kids are programmed to play, aren't they? So if you're going along with that and you're on that same sort of level, then they're going to feel more relaxed and you're going to be able to build a rapport with them, and they're more likely to tell you stuff which they don't like doing normally. And you're going to get it's going to be easier for you all round. And then if you want to try and like fill time and chat with them about random stuff, then like literally looking around and seeing what things they have if they're at home, like what their toys, or looking at their clothes, saying that you like what they're wearing and tell me about the character on your top or something like that. Those sorts of things, anything that makes it about them is really important, and it makes it a lot easier for you and really helpful. So yeah, try that.
Perfect. And I'm just going to stop sharing my screen for a second whilst I get up the link for the QR code, just because there's been a couple of questions asking people can't get to it for various reasons. So let me just get this link. I popped the link in the chat, everyone. And you should be able to see it now. And then I'll bring up the QR code again for everybody else. So that's a great answer. And yeah, I think, yeah, rapport. If you're not going down the clinical route, just rapport with the child is fantastic. And what's the YouTube channel name for James for KidConfident? I'm looking at it right now. It's youtube.com/@KidConfident23.
Yes.
Or
And
just
I'll put a
KidConfident23.
link in the description as well. So which is like page just for this webinar, just for you guys. It doesn't link from anywhere else in the website, and it's got all the resources and stuff that I've talked on, and there's obviously a link to the YouTube channel there.
Brilliant. So I'm just going to leave this open for a couple more seconds, because I always, as I do this every single week, where we say we're going to wrap up and skip past stuff, and then suddenly questions start flooding in. But I think Dawn has done such a great job tonight of answering the questions in the chat that they've not come in at the end instead. So well done, Dawn.
Dawn is really good. She's one of the lead lecturers at it's Bradford or Cumbria. I can't remember which one it is. The University of Medicine. And so she's at Bradford. Yeah, Bradford. I knew that. And yeah, so she is a really good resource for asking questions to and stuff, and she knows what she's talking about because that's her job.
And thank you for dragging all the students here as well, Dawn. I personally really appreciate it. So thank you very much for your help tonight in the chat behind the screen. It's much appreciated. And of course, as always, as I click next nothing's coming. As always, thank you to our sponsors of Trauma Care, as well as Slater and Gordon. We are supported by the wonderful QualSafe, who again you can find at the Trauma Care conference. They are running the first aid program on the Monday, so do go and check them out. They've got a really practical program put together with the likes of St John Ambulance, QualSafe. I think there's a couple of others in there making an appearance, but yeah, do check them out. Scan the QR code that's on your screen. Just go to qualsafe.org. You don't need to go to awards anymore. So thank you very much. What they do as well, just so everyone knows, as there are lots of students in here, which is really good to see. QualSafe do a load of FREC 4 courses, a lot of free up courses, lots of first aid courses with certification at the end of it. So if you scan the QR code on your screen, go to the website, they've got lots of courses available. They aren't free, unlike, so do check them out, and they've got lots of informative things there. And of course, our good old friends Galen with the double trauma care on there, because, if it's nice, make it twice. Do scan the QR code that's on your screen to find out more about them, as I am not qualified. I can't speak too much on them, but I can speak highly of them. And a lot of you will get to know this brand in your professional life. So do scan the QR code that's on the screen, find out more about all the different pharmaceuticals that they have available, because it's good learning to know. And that is everything for this evening. Thank you all so much for joining us. And thank you. It's so good to see so many students here as well. It's absolutely brilliant to see you. Thank you, James, as always. I can't remember off the top of my head when you're with us next. I think it's just after the conference. I think. Yeah. So James will be back with his second sort of installment in the Pediatric series just after the conference in March. And of course, if you are coming to the conference, come and say hello to both myself and him. We'll be wandering around. Well, James will be there on I want to say Wednesday off the top of my head. So yeah, brilliant. Thank you all very much. Wherever you are in the world, I've seen people from Australia and from all over tonight. It's wonderful seeing you all. Wherever you are in the world, take care of yourself, take care of your loved ones. Have a good evening all, and good night.